What the Study Says.
Welcome back to What the Study Says. I'm Dr. Kai.
And I'm Dr. May. Have you ever had that cough? You know the one, that relentless, nagging hack that just won't quit?
Oh, yeah.
Keeps you up at night, interrupts everything. You might even wonder if, your lungs are staging a breakout.
Right. And it's more than just annoying, isn't it?
Yeah.
The force behind it is actually incredible.
It really is. We're talking about clearing your throat with speeds over 500 miles per hour.
Wow.
Yeah. Pressures up to 300 millimeters of mercury. Energy reaching, 25 joules? Enough to launch something small.
It's a vital defense mechanism when it works right.
Exactly. But when it doesn't stop, well, it can be truly debilitating.
Absolutely. And that's precisely why today we're taking a deep dive into the really complex world of chronic cough.
Mm-hmm.
Our insights today are drawn from a cutting-edge 2025 review article. And this is straight out of one of the most authoritative medical journals out there,
Yeah.
the New England Journal of Medicine.
The NEJM, yeah. Very respected.
Exactly. And our mission really is to cut through the complexity of this global health challenge.
Right.
We want to give you the latest understanding of what chronic cough actually is, why it's often so frustratingly hard to pin down and treat.
Yeah.
Some surprising new insights into how it works, the mechanisms, and what all this means for you, for patients, and for clinicians too.
Okay, so let's start with a really crucial distinction, because even that word chronic, it has a very specific medical meaning here, doesn't it?
It does. Duration is key.
Yeah. So when we talk about cough, we categorize it by how long it lasts. An acute cough, that's less than 3 weeks.
Like after a cold.
Right. Then there's subacute, which is between 3 and 8 weeks. But anything stretching beyond that 8-week mark, that's officially a chronic cough.
And that 8-week threshold, it isn't just arbitrary, is it? It's a clinical signpost.
Exactly. It's a signal.
Yeah.
By then, those coughs you get after a cold or the flu, they really should have cleared up.
They should be gone.
If it's still hanging around after 8 weeks, that's a red flag. It tells us it's time to dig deeper, maybe consider a more thorough evaluation to avoid potential complications down the line.
And the burden of that persistent cough, gosh, it's so much more than just being annoying.
Yeah.
The article really highlights the extensive negative effects. Beyond just, potentially spreading infections. The sheer physical force of coughing can lead to some pretty severe symptoms across different organ systems.
Like what specifically?
Well, things like stress, urinary incontinence, especially in women, feeling faint or even passing out, that's syncope. And in very rare, really extreme cases, it can even be fatal.
Wow.
But it's not just physical. The psychosocial side, the functional impact, the emotional toll, it's immense. Patients talk about fear, real fear about their safety, deep embarrassment, major disruptions to daily life.
You can see how that would happen.
And if you connect this to the bigger picture, it's really no surprise that chronic cough is one of the most common reasons people end up seeking medical attention. The healthcare costs associated with it are just staggering worldwide.
So given that significant burden you just laid out, it really begs the question, who's most affected? Who's dealing with this?
Right.
The epidemiology, the study of who gets it, as the article shows, has some really fascinating insights.
It really does.
Like, studies in the UK show the prevalence, how common it is, ranging between maybe 2% and almost 5% in the general adult population.
Which is quite a few people when you think about it.
It is, but here's where it gets really striking. There's a clear sex difference. Women significantly outnumber men.
Yeah, I saw that, around 57, 58% in some studies.
Exactly. Quite a margin. So what does this actually mean? Why the difference? The article gives us a couple of powerful reasons. It's not just random.
Okay.
First, women seem to have a more pronounced cough reflex sensitivity. They react more strongly, essentially, to certain inhaled irritants compared to men.
Interesting. Like a more sensitive trigger.
Kind of, yeah. And second, chronic cough just seems to hit women's health-related quality of life harder, often because they're more susceptible to those physical symptoms you mentioned, like stress urinary incontinence.
Ah, right. Which carries its own significant psychosocial impact. Embarrassment.
Totally. And that often leads them to seek medical help more frequently, which might also skew the numbers a bit, but the underlying sensitivity difference seems real.
That leads us neatly into this whole area of the unexplained cough. It's a term that gets thrown around a lot, often misunderstood.
Right.
But the article clarifies it really well, based on a 2016 international expert panel. So unexplained chronic cough means a complete guideline-based investigation finds absolutely no underlying cause.
Okay, thorough check, nothing found.
Exactly. Then there's explained but refractory chronic cough. That means we know the underlying disorder, say asthma or GERD, but the cough just keeps going despite treating that specific condition.
So the treatment isn't working for the cough part?
Precisely.
Mm-hmm.
And finally, there's unexplained refractory chronic cough, URCC. That's when no cause is found, and it doesn't respond to any empirical sort of best guess therapy either.
Got it. That sounds like the toughest category.
It is, and there's been this persistent misconception, and you sometimes see figures suggesting up to 60% of chronic coughs are unexplained.
Yeah, I've heard that.
But this rigorous systematic review, it found the prevalence of truly unexplained or refractory chronic cough, URCC, is actually much, much lower. It's closer to 10.5%.
Only 10.5%. That's a huge difference from 60%.
It's a massive difference, and it really changes things. It means that for the vast majority, around 90% of people with chronic cough, a thorough investigation can find an underlying cause if we follow the right steps.
That's actually really hopeful. It pushes back against that idea that, oh, it's just a cough or maybe it's psychological.
Exactly. It empowers both patients and clinicians to keep searching, because chances are there is an answer.
Okay, so to really understand why finding that answer is possible, maybe we should dive into the neuroscience a bit. How does coughing actually work?
Yeah, let's do that. It's way more complex than just a simple throat tickle.
Right. So the cough reflex, it's mainly mediated by the vagus nerve. Think of it like a superhighway carrying signals from the lungs, but also other organs, maybe even the nasal passages via trigeminal nerves.
A big network.
A big network. And we're talking specific nerve fibers here. A fibers are like the fast alarms for sharp stuff, mechanical irritation, acids, and then C fibers, which are slower, deeper sensors for things like tissue damage, inflammation, general irritants.
And they have specific detectors, right? Receptors.
Exactly. Receptors like P2X23 and P2X3. These act like chemical sensors, picking up on signals like ATP, which gets released when airway cells are damaged or inflamed. It's a danger signal.
Okay, so the nerve endings detect the problem. Where do those signals go next?
They travel up that vagal highway to the brainstem, specifically to the medulla oblongata, and an area called the nucleus of the solitary tract. That's kind of the brain's cough command center.
The command center, okay. But it's not just a simple reflex arc, is it? Like knee-jerk reflex?
No, not at all. And this is the kicker. Higher brain regions get involved too. Areas like the midbrain, the primary sensory cortex. fMRI studies actually show these areas light up, meaning they actively modulate, they process, they can even amplify the cough response. Our brain isn't just passively receiving a signal, it's actively shaping how we perceive that urge to cough and how strongly we react.
Which leads perfectly into this concept of cough hypersensitivity syndrome.
Right. Explain that.
Well, it's this idea where a cough gets provoked by really low levels of triggers, things that wouldn't normally make someone cough, like cold air, perfumes, talking.
Okay.
And it's often preceded by these sensations like a tickle or this overwhelming urge to cough that you just can't control.
So is this like a distinct condition, a separate diagnosis?
That's the question the article raises. While these symptoms are super common in people with chronic cough, the article suggests this hypersensitivity might often be transient. It doesn't necessarily mean someone has a unique, permanent chronic cough type. In fact, many patients who describe these exact symptoms still end up responding well when you find and treat one of the common underlying causes, like asthma or reflux.
So the hypersensitivity might be a symptom of the underlying problem rather than the problem itself.
That seems to be the thinking. The theory involves neuropathic changes, sort of like nerve sensitization, in that vagal signaling pathway.
Okay.
And those fMRI findings you mentioned are really key here. They suggest these changes, this amplification, might actually be happening more in those midbrain regions rather than just being a problem solely in the peripheral nerve itself.
So the brain's interpretation or amplification is part of the issue.
Potentially, yes.
Yeah.
It shifts our focus a bit towards how the brain is processing these signals.
Okay, this understanding really helps challenge some common diagnostic misconceptions then, things we might have learned or assumed.
Definitely. The article is quite direct about some historical clues that, it turns out, are not that helpful for figuring out the cause of chronic cough in adults.
Like what? Give us some examples.
Okay, things like the character of the cough. Is it dry? Productive? Does it sound like a honk or a bark? Is it paroxysmal, coming in fits? Or brassy? Turns out none of that reliably points to a specific underlying cause.
Really? Not even a barking cough?
Nope. Or the timing. Does it happen mostly at night, with meals, after meals? Again, not very helpful for diagnosis. Even serious complications like fainting, syncope, or coughing up blood, hemoptysis. They don't reliably tell you why the cough is happening.
Wow, that dismantles quite a few classic clues.
It does, and here's a big one. That common belief that if someone doesn't cough during sleep or if they have that barking or honking cough, it must be psychological, like somatic cough syndrome or a tick cough.
Yeah, I've definitely heard that link made.
The article states that's a common misunderstanding. These features are not definitive signs of a psychological cause. And to make this really clear, there's a figure in the paper, figure 2. It shows endoscopic views of the larynx, the voice box.
Okay.
You see the vocal cords before a violent cough looking relatively normal. Then you see them immediately after, red, swollen, clearly irritated.
Right, you can literally see the trauma.
Exactly. So the article suggests that maybe activities like singing or even just talking provoke coughing, not because of some specific laryngeal hypersensitivity syndrome per se,
But because
those actions are further irritating vocal cords
Yeah.
that are already traumatized and inflamed from the violent coughing itself. The cough causes the irritation, and then using the voice just makes it worse.
That makes so much sense. It's a physical irritation cycle.
Precisely. The act of coughing itself is traumatic to the tissues.
Okay, understanding the complexity, the neuroscience, busting the myths, that's one thing. But what about actually treating it, getting relief?
Right. Moving into treatment. Beyond just that 10.5% of truly unexplained cases, the article points out some very real, practical barriers to managing chronic cough successfully.
Even when a cause is found?
Yes. The existing evidence-based guidelines for chronic cough, they are highly effective when followed properly.
Okay.
But the article notes they are also incredibly detailed and time-consuming.
Which can be tough in a busy clinic.
Exactly. This can make it hard for clinicians to follow them perfectly every time, what the article calls challenging fidelity. Or sometimes clinicians might unfortunately be using older, out-of-date guidelines.
Right, things change.
Then there are what's called interventional fidelity issues. This covers both how treatments are actually administered and the patient's ability to follow the recommendations. Think provider factors and patient factors.
Can you give an example?
GERD, gastroesophageal reflux disease, is a prime example where fidelity can be poor.
Yeah.
Maybe the doctor prescribes acid suppressants, but the patient doesn't take them consistently.
Or doesn't do the lifestyle stuff.
Exactly. Or maybe the crucial lifestyle changes. Diet, weight loss, avoiding intense exercise right after eating aren't clearly explained or emphasized, or the patient finds them too difficult to stick with, so the treatment doesn't work as well as it could.
I see. And what about the psychological side? You mentioned anxiety and depression earlier.
Yes, and this is a nuanced but really important point the article makes. Depression and anxiety are common complications that arise because of the chronic cough and its impact on life.
Okay, so they're a result, not usually the root cause.
More often than not, yes.
Yes.
Mistakenly jumping to the conclusion that the cough itself is primarily psychological can actually delay finding and treating the true underlying physical cause. It's crucial to address the anxiety and depression as part of managing the whole person, but not at the expense of a thorough physical workup.
Okay, that's a critical distinction. So what are the recommended steps then, especially for those folks who might initially seem to have that unexplained or refractory cough, the URCC?
The approach should be systematic. Step 1 is basically to go back and systematically identify any potential barriers to why the updated guidelines might not have worked so far.
Like checking if things were missed or not treated optimally?
Exactly. Was rhinosinusitis managed properly? Could it be cough variant asthma, where cough is the only symptom? Was non-asthmatic eosinophilic bronchitis, NAEB, properly looked for and treated? It requires specific tests.
And GERD, you mentioned it's tricky.
Very tricky when it's causing cough. Acid suppression often isn't enough on its own. Those lifestyle changes are absolutely vital, but, as we said, hard to maintain.
Right.
Plus, there's that vicious cycle. The cough itself can actually trigger reflux events. So coughing makes reflux worse, and reflux makes coughing worse.
Ugh, sounds frustrating. Okay, so that's step 1. Double check everything. What's next?
Step 2, if it hasn't happened already, is usually a referral to an interdisciplinary cough clinic.
What happens there?
These clinics bring together specialists, maybe pulmonologists, allergists, ENTs, gastroenterologists, speech therapists, to do an expert review of everything that's been done so far, all the evaluations and treatments, a fresh set of expert eyes.
Makes sense. And if, after all that, it's confirmed as truly URCC, that 10.5%.
Then you move to step 3, considering specific evidence-based treatments for the cough reflex itself.
Okay, what are those?
One major one is multimodal speech therapy.
Speech therapy for a cough. How does that work?
It involves educating the patient about their cough, teaching specific techniques to suppress the urge to cough, and breathing exercises to help control it. And it's actually proven effective in randomized trials.
Huh. Why does it work?
It might tie back to that brain involvement we talked about. The therapy might help retrain those cortical pathways, giving the patient more voluntary control over the reflex.
Fascinating. What else is in step 3?
Pharmacologic neuromodulation, using medications to modulate that overactive cough reflex.
Like what kind of meds?
These are often centrally acting drugs, things sometimes used for nerve pain or other conditions. Examples include amitriptyline, gabapentin, sometimes low-dose morphine, baclofen, nalbuphine. They seem to help calm down that hypersensitive reflex in the brain.
And combinations.
Yes, there's also evidence for combining treatments. For instance, speech therapy combined with pregabalin, another neuromodulator similar to gabapentin, has shown success.
Okay, lots of options there, but medications always have side effects, right?
Absolute crucial point. While these neuromodulators can be helpful, it is vital to have a thorough discussion about the potential adverse effects.
Right.
And to periodically reassess if the benefits still outweigh the risks. For example, there's a known increased risk of severe exacerbations, flare-ups, with gabapentinoids, that's gabapentin and pregabalin, in patients who also have COPD. So real caution is needed there.
Good to know. Any other treatments mentioned?
Superior laryngeal nerve block is mentioned, but the evidence for it is pretty limited currently. It's more invasive too.
Okay. And what about that anxiety and depression we talked about?
Right, it's important to circle back. Again, these are often complications. The good news is they frequently improve as the cough itself gets better under treatment. Addressing mental health is definitely part of holistic management, but it shouldn't replace the search for the cost trigger.
Okay, so that covers current management. What about the future? Are we getting closer to that, magic bullet for cough?
Well, the search is definitely on. And here's where it gets really interesting again, the ongoing hunt for pharmacologic antagonists, drugs that block those vagal signaling pathways involved in cough hypersensitivity.
Okay.
The article discusses the story of gefapixant. This was a P2X3 and P2X23 receptor antagonist targeting those ATP sensors we mentioned.
Ah, right. Did it work?
It showed some initial promise, and it actually got licensed in places like the EU and Japan. However, ultimately, it was only marginally more effective than placebo in large trials.
Only marginally.
Yeah. And crucially, the FDA in the US did not approve it. Plus, it came with a significant side effect. Substantial taste disturbances. A lot of patients found that quite bothersome.
Taste problems. Not ideal.
Not ideal at all. So gefapixant's story is maybe a bit of a cautionary tale, but it also shows that targeting these specific pathways is a valid approach, even if that first attempt wasn't the home run everyone hoped for.
Sure. The search continues.
Definitely. Research is ongoing with other similar purinergic antagonist drugs like eliapixant, camlipixant, sevapixant, and others are in various stages of trial. They have different selectivity profiles, different potential side effects, like eliapixant had some initial concerns about liver toxicity that need monitoring.
Any other types of drugs being looked at?
Yes, there's research into other neural signaling inhibitors too, like sodium channel blockers or even TRPM8 agonists. TRPM8 is a receptor involved in sensing cold, which can sometimes suppress cough. There's even interest in natural compounds like quercetin.
So lots happening, but no breakthrough just yet.
Pretty much. The article concludes that a safe and truly effective pharmacologic treatment specifically designed for cough hypersensitivity remains an unmet need. But the ongoing research is active and offers real hope for the future. The need is huge, so the motivation is there.
Okay, let's try to bring this all together then. Our deep dive into this NEJM review has really unpacked a lot about chronic cough.
It really has.
We've clarified that crucial definition. A cough lasting over 8 weeks needs a closer look. We've busted that myth about unexplained cough being the majority. The real figure for truly unexplained or refractory cases is much lower, closer to 10%, which is actually good news.
It means answers are usually findable.
Right. We've touched on the complex neurobiology, the vagus nerve, the brain's role. We've seen how some classic diagnostic clues, like the sound or timing of the cough, aren't as helpful as we might think. And importantly, we've outlined the current best approaches. Systematic evaluation, addressing underlying causes like GERA or asthma properly, and then for the tough cases, options like speech therapy and neuromodulators, always weighing risks and benefits.
It emphasizes a thorough, holistic approach.
Exactly. Not just trying to suppress the symptom without understanding the cause.
And I think this deep dive really shows us that a cough isn't just some simple symptom to be silenced. It's actually a complex signal from this highly interconnected system, nerves, brain, environment, all playing a part. Understanding its subtle messages and really challenging our own assumptions about why someone is coughing, that's absolutely key if we're going to truly find lasting relief for people suffering with this.
That's a great final thought. It's about listening to the signal. Well said. If this deep dive resonated with you, or if you know someone who's been battling a persistent cough, please subscribe to What the Study Says and share this episode. It might offer some valuable insights or even spark a new conversation with their doctor.
Absolutely. Knowledge is power.
Thanks for joining us. We'll see you next time for another deep dive.